All right, here we go. So, here is our feel good for today. What we are today is a result of our own past actions. Whatever we wish to be in the future depends on our present actions. Decide how you have to act now. We are responsible for what we are now. Whatever we wish ourselves to be, we have the power to make ourselves. Thanks, therapy. That's a lot of what I learned in many years of therapy. So you get to do whatever you want to do. Go for it. That's why you're here now. A lot of you guys are here now making big choices. It's lovely. All right, here we go. What are some risk factors for skin breakdown that are unique to the older population? Why do we care about skin breakdown in our older population? Infection, yeah, that's a big one. Yeah, that's how thin their skin is. So it makes it very, a lot easier for skin breakdown to happen, right? What else? They're less mobile. Yeah, that's a huge one. All right, we're going to dig into skin today. So here we go. Freaky AI people going on there. Too bad we can't do that as we age, right? So some objectives include identify skin conditions commonly found in older and later in life. We'll look at prevention, maintenance, and restorative measures for skin health. We'll look at risk factors for pressure injuries and describe nursing actions for prevention and treatment. And then we'll analyze the cues of skin problems in older adults and implement actions for to promote skin health. For hair, skin, and nails, a lot of what happens to damage them has to do with modifiable risk factors. Some is absolutely genetics, and we have people who are just gifted and blessed with amazing, beautiful skin from their parents, and then the rest of us are damaging our skin every time we walk outside. And we have that from sun radiation, pollution that we deal with, the lack of sleep that happens during nursing school, temperature exposure from very hot to very cold, stress from nursing school, nutrition, good or bad, And our patients that are immobile or medically fragile are even at greater risk of having skin breakdown or disease that can impact their skin. So we want to be watching for fungal infections, for bacterial infections, and for pressure ulcers. Here are some common facial wrinkles that are described. So frown lines are the ones that are up here. We have crow's feet that are next to the lines. Tear troughs are under the next to the eyes, under the eyes. Bunny lines, the nasolabial folds, which are actually a big problem for patients who are on oxygen. Marionette lines, mental creases, and then we have neck lines. So those are some common ones that you may see described in patient charting. And then we have some natural skin changes that happen as we age, both with the dermis and the epidermis. And then generally we have subcutaneous fat that's reduced as we age. With the epidermis, we have melanocytes are decreased for our pale skin folks. And then we have lentigines, our age spots or liver spots. That's just as we age, we start to get these brown spots. They are benign. I didn't really think that that was happening. I will admit that I'm slightly vain, and something happened, and I looked down, and I was like, "Oh, I have my grandma's hands," and it was because of a certain spot, and I was like, "Yeah, cool. Not happy with that, but oh well, can't change it." Although I do think that dermatology may be something that that's a nice nursing field to go into. They don't take any call any time, FYI. We have decreased thickness in our skin, which was mentioned before. Very fragile capillaries, which is how just a little bump will end up with mass bruising. Decreased stretch and elasticity. There is decreased sweat production. And then we have differences in color and temperature as well. Well, and doggone it if we don't have decreased melanin production, which reduces the color in our hair. So we end up with dark hair turning gray. And then diffuse alopecia occurs in both genders, where we have both balding and thinning. We lose hair in certain places, and then we increase hair in other places that we may not want it. Specifically in males, we see the increased hair in eyebrows, nose, ears. Ladies may end up, because of hormones, with hair where it's not supposed to grow typically. A lot of this is genetic related, especially when it comes to balding and thinning. Nails, we see a lot of thickness and brittle nails, as well as flat and concave with vertical ridges as somebody ages. Some of this can be related to nutritional deficiencies, but some is just through aging, not necessarily related to deficiencies. When we do a skin assessment on our patients, which we should be doing a skin assessment on all our patients. And I have to say, about last week, the week before, I had a family member who was in the hospital, and I had the distinct pleasure, I guess, of being with them when they went from the ER to being admitted to the floor. And this nurse was so thorough on her skin assessment. I was so impressed. She didn't know I was a nurse, because I don't just throw that information out for anybody. But she had my family members stand up, and she was like all the crevices, looking and pulling and everywhere, assessing that skin. I was so impressed. I was like, hands down, amazing. But we want to inspect. We want to be looking everywhere, because our patients deserve to have every aspect of their skin checked to ensure that there's nothing that we're missing. If they have just the slightest little start of something and then they lay in bed on that, they have the potential for a massive skin breakdown. And I have like 20 papers still to grade. I'm trying so hard, I promise. But for those of you guys who did skin integrity or wound care, wound breakdown kind of stuff, you'll remember from the research you guys did how important having utilizing Braden scale and watching for those patients that have fragile, translucent skin, how vital it is to really do a good assessment of those patients. We also want to know what kind of history do they have when it comes to skincare. Have they had a ton of exposure to the sun, or were they the 90s kid of sitting in a tanning bed? I was a lifeguard in my teen years and was sunburned entirely too many times. But I had a great tan. It was amazing. I'll probably pay for it though. Do they have cool, dry skin? Is it nice and moist? Is it hydrated? What does it look like? We want to be able to identify all those things with our patients. All right, so looking at some common skin problems, we have, we're going to identify each of these individually. The top one here is seborrheic keratosis, and then the next one with the little red dots is cherry angiomas. The far one is purpura, which is between like it's little tiny bruises, and then herpes zoster, and then we have varicose veins, leg ulcers, and varicose eczema. So it's eczema that's surrounding varicose veins. So xeros is abnormally dry skin. So this is, now, yes, in Colorado, we have horrifically dry skin because we have like zero negative humidity in our air, right? Some of what we deal with is, number one, do we have health status that could contribute to why our patient has such dry skin? And then what are they doing for it? We want to make sure that our patients are well hydrated. If they're on a fluid restriction, is there something that we could be doing externally, like lubricants or moisturizers, that can help with that? We know that taking a hot bath is not great. It leaches the skin of any moisture that it may have. So we want to have tepid baths, short baths, and then use a very, very mild soap if they're using any cleaning products when they're bathing. And then instantly put on a moisturizer afterwards. These are some of the popular ones that dermatology recommends for extreme dry skin. Pruritus is a consequence of xerosis or dry skin. This is just itching, a rash. Usually it does not have any sort of raised like bumps or anything. So we just call it itching. Contributing factors are oftentimes some sort of underlying reaction to something, whether that's a perfumed product, fabric softener, something that irritated them. So prevention is really going to be the biggest thing that we can do here. We can have it accompany an underlying medical problem, like a pancreatic problem, liver failure, and that is because of the toxins that are in their body. And it's just really that underlying medical issue, and they're just trying to get it out. All right. Trigger warning for bugs. Scabies. Burrowing mites and eggs, highly contagious. Gross. You can, it makes my skin crawl just looking at them. They look like tiny little, it actually looks like a rash from afar. The way we diagnose this is with a skin scraping and send it to lab, but really you can see the tiny little mites. It is not from being unclean. You just get infected with them. And there has been a couple long-term care facilities that have had the entire facility infested with scabies, and the whole place has to be like, everything has to be cleaned, hot water, mattress. It is a whole thing. I would rather take care of a C. diff patient than a patient with scabies, because C. diff doesn't jump in your hair. Yeah, they give oral medications in some cases, but otherwise it is like full on hot water bleach cleaning situation. Okay. Cherry angiomas are benign vascular lesions. They kind of come up. Sometimes as a person ages, they may have a small one and it gets larger as they age. There's no problem with them. However, because they're vascular, if they get bumped, they bleed like a son of a gun, and they will bleed and bleed and bleed and bleed. So they may need a like a pressure dressing on them if they bleed, but they are not. They're not cancerous or anything, and they shouldn't be painful. The hands is just easily ruptured blood vessels, minimal trauma. So poor patients just end up with, it's not necessarily like, it's not skin tears because their skin is still intact, but they just bruise super easy. If they're on a blood thinner, it's much worse. We want to do prevention to keep patients from ending up looking like this. If they are using like a wheelchair and they're trying to propel themselves, maybe even putting on like cloth gloves or something like that can help. They should wear long sleeves and long pants to help reduce the risk of further damage. All right, skin tears. We want to identify high-risk patients. Any patient that's a dependent individual does fall into that high-risk category. Having them wear long sleeves and pants helps. Keeping their skin hydrated and lubricated is really important. Transferring with as much care as possible, also important. If they have any sort of device that they're using, cane, crutches, walker, wheelchair, use caution around that, because especially like a walker or wheelchair, they have sharp edges and can easily cause a skin tear. We want to substitute adhesive tape for the softer paper tape whenever we can. And then if it happens, we have ways that we need to get that skin back where it needs to be. We don't want to just leave it crumpled like it is up here. So clean the area with normal saline, and then try to pull that back into the normal position. If possible, secure it with tape, and then use a non-adherent dressing and cover it. And then we do have a Payne-Martin skin team classification tool, and this actually categorizes skin tears, which is how they would document the skin tear. Patients with a skin tear should get a referral to wound care, because they can be incredibly challenging to heal, especially if they're large like this one. They actually could lose that whole area of skin, and and cause quite a bit of breakdown. So smaller ones like this category 1A may not be that big of a deal, but as soon as you start losing like category 3, they lost that entire section of skin on top. That is going to be incredibly hard to keep that patient healing, because now that is just open and oozing. And if it's large enough, we now are worried about fluid and electrolyte imbalance for this patient. So yeah, it's a big deal. All right, keratoses. They're generally benign, more common in adults age 65 and older. We often see them on the trunk, the face, neck, and scalp. They can be just one singular little blob, like the size of a top of a pencil, or they can get much larger. Most common in men, and they can have like a tag-like waxy raised appearance. They are, because they're benign, there's no reason to have them removed, but people may remove them for cosmetic reasons. And they do vary in pigmentation. There's actinic keratoses. These they're called actinic because they actually look a little bit like acne, which when you're older, for the love of everything, do we really have to deal with aging and have acne? But they're actually precancerous, and it's related to years of UV light exposure. It's most often seen on the face, surrounding the lips and forehead, and then forearms. Common in old age, especially those with fairer skin, and it does require monitoring with a dermatologist every 6 to 12 months to ensure that it does not develop into cancer. Herpes zoster or shingles. Risk factors include immune suppressed adults, being older, having the chickenpox, stress, or illness. You guys remember learning about dermatomes? The line, the person, and then the lines that come out from the spine. So dermatomes are essentially your nerve, the way your nerves come out along your body. So when it says a skin eruption along a dermatome, it's actually how the virus travels along a nerve line, which makes it incredibly painful. There's itching, tingling, and pain before you ever see any outbreak. And it will follow, you see how with this guy, this first one here, it's like right along that rib. That is right along a dermatome. And he probably had like pain. He'd go to itch and be like, oh, why does that hurt? There's nothing there. Before he ever saw anything. And then afterwards, once that's healed, you could still have pain there. It is highly contagious. If somebody who is younger comes in contact with it, who is not vaccinated for chickenpox, they can get chickenpox. Somebody who's older can get shingles. It's treated with antivirals as well as analgesics to help with the pain, and like gabapentin to help with the nerve pain. So it's definitely needs, patients need to know about it the soonest that they can get. The recommendation for the Shingrix vaccine is usually at 55 or 60. Earlier if they are immune compromised. And but knowing, hey, if you have this type of itching, burning, pain with no other symptoms, to still see the doctor. And just because you have it once doesn't mean you can't get it again. You definitely can get it again. And so long as they have spots, they're contagious. The blisters have to have broken and scabbed over to no longer be contagious. Candiditis, yeast infection. This is the presence of, it's on externally on the skin of individuals at any age. We see this as a diaper rash on little kiddos, in skin folds. It grows in warm, moist, dark areas. So armpits, in the groin. Thrush is candida in the mouth. Patients who are immune suppressed or on steroids are more prone to have to develop it. Skin cancers, we have basal cell carcinoma and squamous cell carcinoma. This is just simply related to prolonged exposure to UV light and overexposure to the sun. So prevention is exactly that. Limit your sun exposure and use sunscreen regardless of your skin tone. So if you're the one who's like, but I tan so nicely, I don't even burn. It don't matter, put the sunscreen on. Here is the difference between benign and malignant, and we use the ABCDE to look at it. So we look at asymmetry. Is it a nice round circle, or is it lopsided? For the border, do we have the edges nice and smooth, or are they uneven? The color, is the color all the same across the entire thing, or are there varying shades of color across it? For the diameter, benign moles tend to be smaller and they tend to stay small, versus melanomas tend to be larger than an eraser head and become larger over time. And then evolving, common benign moles are the same over time. And then for malignant, they are evolving. They start to change over time. For the different types of skin cancer, we look at basal cell carcinoma. This is the most common type of skin cancer. It occurs in older adults. It is most prevalent in our light-skinned people. Risk factors include sun exposure, and it's really that chronic irritation and chronic ulceration of the skin. And they treat with simple excision or Mohs micrographic surgery. For squamous cell carcinoma, this is the second most common skin cancer. It has the highest risk for those in their mid-30s and have had chronic exposure to the sun, found on the head, neck, or hands. These are treated with electrodissection or curettage, Mohs surgery, cryotherapy, or a topical treatment. Melanoma is less than 2% of skin cancer, but results in the most skin cancer deaths. Melanoma is the one that is most likely to metastasize. Risk factors include history of previous skin cancers, atypical large and numerous moles, sun sensitivity, blistering sunburns, use of tanning booths, blonde or red hair, immune suppression, appears on the legs and backs of women and on the backs of men, metastasizes quickly. So the most important part as a nurse is education, community awareness, education programs, screening clinics, regular skin checks using the ABCDE approach. for status dermatitis. How many of you guys are starting to notice people's legs when you go to the grocery store? So you're checking out arms for IVs, right? You're like, ooh, I can hit that from across the room, right? That's a good one. That's a juicy vein. But now you look down, you're like, ooh, ooh. Oh, sweetheart, you need some compression stockings, right? So stasis dermatitis is that chronic inflammatory dermatitis because their legs are not getting that good venous return. And so they end up initially with just like a little rash, maybe some varicose veins, and then because of that constant irritation and increased permeability, they actually have skin darkening that happens. And then over time, it thickens and then can have skin breakdown. So some risk factors include just faulty valves, obesity, prolonged standing or sitting, or an injury. Hint now, start wearing your compression hose when you work. Your legs will thank you later, and nobody will be looking down at your legs going, huh, looks like they need some compression hose. I promise you. All right, when assessing the skin of an older adult, which finding is of most concern? Which one are we worried about? Yeah, so this lesion could be malignant and immediate follow-up is needed. Yeah, any moles that are irregular, concerning. And keep in mind, for patients, anything that's on their back, like their backside, if they haven't seen it, ask about it, because people don't normally look at their backside, right? So, and if they live alone, I would ask, have you seen this XYZ on your shoulder? Has somebody looked at this? Because if they live alone, somebody probably has not looked at that, and somebody needs to look at that. All right, pressure injuries. This is localized damage to the skin and underlying soft tissues. We have about 70% of all pressure injuries are within our older population. And the key to this is prevention, right? We don't want them to happen in the first place. Medicare and Medicaid will not reimburse if you cause a pressure injury. So when I mentioned that nurse was so thorough with my family member and they were checking out every single part, well, that's because if at the end of that hospital stay, my family member had a pressure injury, they can now prove, well, guess what? That pressure injury happened while they were in the hospital. And now Medicare, Medicaid is not going to pay for that entire visit on the responsibility of a hospital because they caused that pressure injury, right? Or if they didn't do that assessment and said, well, no, they came in with that pressure injury, but they have no proof, Medicare, Medicaid, who's going to pay for it then? Pressure injuries are extraordinarily costly to treat. It increases the patient's morbidity and mortality. And so we really, really, really want to avoid having these happen to our patients at all costs. They primarily occur on the sacrum, heels, and greater trochanters. And people who have peripheral artery disease are at higher risk for on their heels. Other areas, check those ears, baby. People who wear glasses and have oxygen, which I have way too many things hanging over my earlobes right now, okay? Glasses, hearing aids, oxygen tubing. There's so many things pressing on my poor little ears. I feel bad for patients now. Risk factors. We want to watch for skin changes, other comorbidity issues that our patients could be dealing with. What is their nutritional status? Have they had any recent surgical procedures? What is their cognitive status? If they can't physically move themselves around, are they going to be able to tell us when they have something going on? And incontinence is going to be another huge factor here. Now, for life, when you have a patient who is in their end of life, we typically disregard our concern for pressure injuries, because now it is a matter of keeping that patient as comfortable as possible, as opposed to we're going to turn this patient every hour. And so that is the one time in which we are not hyper vigilant as when it comes to prevention of pressure injuries. Big thing with pressure injuries is prevention. So it needs to have every place needs to have a comprehensive program that includes patient education, family education, training all of the team members from our patient care techs, our nurses, and having prevention bundles that works with risk assessment, skin assessment, nutritional assessment, frequent repositioning, and then appropriate support surfaces. That means that any place that has those prominent bony surfaces are getting nice and padded whenever possible. For using clinical judgment related to those pressure injuries, we want to make sure that the nursing staff is working together with the rest of the healthcare team, and everybody has a piece of that where everybody is looking at skin. Everybody who notices any changes in that skin has a responsibility to report that. Anybody who notices risk factors, identifies those, comes forward and reports that. There's a push tool where there's the perform the skin assessment. We're utilizing the tactile and visual assessment of the entire skin surfaces with special attention to the bony prominences. Looking at nutritional health to ensure that that's being done, being upheld to the best of our ability. And then the Braden scale is another very important tool that we use within skin assessment. This is where we're looking at the risk for developing a pressure ulcer and identifying the 6 different ways that a patient could be impacted from sensory, moisture, activity, mobility, nutrition, and friction or shear. And we use this in conjunction with a thorough history of other risk factors, including age, medication, other comorbidities. For nursing actions that go alongside this, dressing changes with detailed assessments. Initially, it's listed as weekly, bi-weekly, and then as needed. But honestly, patients, every time you are looking at your patient, you can reassess their skin, right? If you are helping them change, you're reassessing their skin. You don't have to do a reassessment. Oh, it's only done every 2 days. It doesn't matter. Go in and chart it. You've had a chance to look at it, chart it. And then when we're selecting wound care, it's based on the condition of the wound, the presence of granulation, necrotic tissue, all of that. And wound care specialty, if anybody's interested in that, absolutely fascinating. If you have a chance to follow a wound care nurse in your clinicals, do it. They are absolute wizards, amazing with what they can do. This is a staging question, and actually as bedside nurses, we do not stage. Staging wounds has to be done by a wound care nurse. So I'm gonna just tell you it's a stage 2. So stage 2 is a partial thickness loss of skin with exposed dermis. The wound bed is viable, pink or red, and moist, and may present an intact or ruptured blister. We do not see adipose tissue at this point, and deeper tissues is not visible yet. So, but the wound care nurse is the one who has to stage a wound. The only thing you would do as a nurse is describe the wound and potentially measure the wound, and say that a wound care nurse has been notified. And then food for thought: what factors impact rest, sleep, and activity as we age? So that'll be for Monday. Any questions? This is in hopes that we'll actually start having some leaves fall, because it's fall.